Okay, great. So it's always fun to get a little student interaction and have some discussion here. I'm going to go ahead and move into my second case, which is going to feature a different thing that we can do with Forum that's a real time saver, and that is looking at progression determination. So as a clinician, I spend really most of my time in the, is this glaucoma or is this not, sort of in the diagnosis aspect of things. But once we say that a patient has glaucoma, you know, our game changes and we're really looking strictly at whether or not we are controlling the disease and whether or not the patient is showing evidence of progression. So I'm going to sort of talk about 4 different things in a quick way as I go through a case. The first thing is, what are the 2 different ways that we can decide whether or not a patient is progressing? And so there are 2 different types of analyses that the software will give us. One of them is event analysis. And I think of event analysis as kind of a yes-no question. Is today's test significantly different from the baseline test? So it's really just yes, no. Is this different? And we're usually going to use event analysis earlier in the patient's disease when we have fewer exams to compare, but we can use it throughout the course of the disease. But usually after we get a fair amount of tests, we're going to depend a little bit more on trend analysis, which is going to create a regression line between a particular parameter of a test and time. So it might, for example, on a visual field, look at the mean deviation over time or the visual field index over time. In an OCT, it might give us average nerve fiber layer thickness over time, or superior or inferior. And so trend analysis is really a way for us not to say, is this changing, but how quickly is this changing? Now, one of the things that's really important, and I don't have a lot of time to get into it, but it's important to remember testing frequency, because it's going to take probably 5 or 6 visual fields before you're able to really determine that that visual field has changed or not. And so if you're only doing a visual field once a year, that means it's going to take you 5 or 6 years to decide if your glaucoma patient is progressing. And so at least initially, we want to increase the frequency of our testing so that we can make that determination a little more quickly. I think sort of the evidence has shown that a really good number of visual fields to try to obtain is 6 visual fields in the first 2 years following the diagnosis of glaucoma. If you're not seeing change after 2 years, then you can back down on the frequency of your testing. Of course, if you're seeing progression in that 2 years, then you're going to get a little more aggressive and you're probably going to maintain frequent testing. And then the last thing that I'll talk about is resetting a baseline once you have made some type of intervention in your patient. So I'll go ahead and get into my case. This is Mr. Garcia, an 86-year-old Hispanic male who I had been following as a glaucoma suspect from 2008 to 2012 because he had pseudoexfoliation. Now, during the time 2008 to 2012, his intraocular pressure was always under 20, but around 2012, his intraocular pressure started to go up, and his highest untreated pressure was actually 24 millimeters of mercury in the right eye. We initiated treatment with latanoprost in 2012. So here are Mr. Garcia's initial optic nerve photos. You can tell they're taken with an old camera. His initial visual fields, which really were pretty normal, and his initial OCT, nerve fiber layer OCT. So at this point, he had normal intraocular pressures, fairly normal optic nerve appearance, and normal visual fields. We just opted to treat him knowing that he did have a significant risk factor, that being the presence of pseudoexfoliation. But as you can see in our GPA, which follows the visual field, in this case, in the left eye from 2009 to 2019, you can see that he has developed, he's gone from sort of a nothing visual field to developing a pretty significant inferior partial arcuate defect in the left eye, and over on the right eye, even more significant changes as he goes from a fairly normal visual field, in fact, looking like the inferior field was abnormal, to having a very well-defined and deep superior arcuate and paracentral defect here. If we look at the same period of time for our OCT, we can see that he clearly developed some pretty significant inferior nerve fiber layer thinning in the right eye, some superior thinning as well, but predominantly inferior. And then in the left eye, we see really pretty dramatic nerve fiber layer loss over that period of time, both superiorly and inferiorly. And so we can look at these slopes. You can see that the average nerve fiber layer thickness is changing at probably, twice the rate of a stable glaucoma patient. We see changes in the superior, inferior, and cup disc ratio as well. But one of the things that I want you to notice is that there's this period of time, about 3 years, where we really don't have any testing. And he had sort of dropped off the map. He had sort of stopped coming in for his regular checkups. He was not really believing that he had glaucoma. And so we have this gap in time. And when he came back here at about age 83, this is when we really got him on board with his therapy. And so what we did at this point is we reset our baselines to this being ground zero, to this visit right here that I'm pointing to with my arrow being the first visit. And the reason is that we know he's had change from all the way back here, but all of this time he hasn't had any treatment. So it doesn't really make sense to include those visits in that time span in our progression analysis. So we reset our baseline to this visit here. And what you see is that those slopes really change. We go from a slope of 2 microns per year to less than half that. We go from a slope of 4 microns per year in the inferior RNFL to -1.5. And we see similar changes here. When we look at his visual field, we again see a relatively flat visual field. So we're not seeing significant changes in this visual field since the time that we initiated therapy. And so you see these 3 little dots right here in our GPA. You see them in both right and left eyes. If we hovered over that while we were in forum, a little bulletin would come up, a little post-it note, if you will, that says initiated latanoprost. And so that would really help me to understand what is going on. Why did I put a little message here? It's because that's when he finally got on board with his therapy. We can use our reports, our structure function reports in forum. This again being Mr. Garcia from the very first time that we saw him back in 2008 or 2009. And we can see that we have change in our visual field. We have change in our nerve fiber layer thickness. We can see that change in our nerve fiber layer thickness here in an event analysis here in our visual field. And if we then re-baseline that patient, we now see a much more flat slope of our nerve fiber layer thickness, of our mean deviation. We no longer see those flags that are telling us that we're seeing significant progression since we initiated therapy.
What a great case, highlighting sort of the robustness of the technology, the capabilities that we have. And sometimes that can be a bit overwhelming. Right? And so we've got to take these times to look at it and digest and think about what's on the screen that's in front of us. Any opportunity, though, that we have to understand the why or how we got to where the data is can be useful. But to start with, what I thought I'd show to those in attendance today is just a little bit inside of Forum, both the capability to do things the way we've always done them, as well as to merge that with maybe new ways to attack the problem. So in this particular case, a 65-year-old male that we're seeing here, and I just want to highlight a few simple case kind of presentation or elements around this individual. So here's that typical or traditional flat report, static report, in which we've got a comparative analysis of the eyes. We've got a T-SNP capability that's in here, and we'll get into in a moment here around on the GPA analysis, where we can actually orient that as an N-SNP or a T-SNP plot. But this is your sort of traditional view that you're used to seeing in that. If we go back up to the top, we can see some more analysis and reporting that was done here, where here's your progression analysis that you're used to seeing. So it doesn't show all of the nerve scans that have been done on here. It's just showing your baseline 1 and 2, and then your last 2 exams, which we can see here are recent here within this last month. These are really helpful reports if you've got nothing else that you can dive into to look at. They've got 2 pages to them. So these are in PDF, they're exportable, printable. Again, another really nice utilization tool. And then maybe even something that some of the attendees are used to seeing here, a panomap. So we're now looking at a full picture of the optic nerve as well as the macula, looking at the ganglion cell and IPL complex associated with the RNFL. Also, again, a really useful tool. And I would say, at least from my perspective, that using this particular view, I'll still come back to stuff like this, because while we get really some keen ability to digest the information, as we'll see here in the structure function for area of glaucoma workplace, it can be useful at times to go back to and refer to these plots where we can look at maybe a different cut or a different slice than what we're looking at here on the screen. So just to orient us all on what's on the screen here, and this is the same individual we were just looking at those reports from. Here in the top quadrant, we talked about this on the previous case, but we've got capabilities to preset these. We can go into, again, just to highlight, we can look at visual field index if I wanted that. If I wanted to quickly change that and say, well, you know, that's not a really critical one for me, and maybe I was using form to record intraocular pressures and I want that listed, it would be available here. These are important places, though, where we can understand our capabilities. And then we talked just a moment ago about looking at a T-SNP versus an N-SNP, being able to flip between those two or toggle back and forth here becomes really, again, an important tool set at digesting the information and looking at deviation versus progression. So in certain cases, when you want to see how a patient is looking, and this is going to look different at today's view than it would have maybe 10 years ago when we first started seeing this individual, but you can see here the individual's map against that normative database. In my clinic, most of us really like to see progression analysis. We prefer the N-SNP versus a T-SNP. The T-SNPs are going to be on all of your more static reports around nerve analysis, but having that N-SNP at your fingertips can be really, really meaningful. To start with, though, on this, what I thought we would go to is some of the new abilities to place into the case now what's happening in terms of clinical events. And so if we look up here where my cursor is, we've got the ability to add new clinical events. Now we can add injections, we can add a medication, a surgery that was done. So if this patient had MIGS, and you'll see that in this case, we would add these in. But let's just start with the medication, for example. And in this particular case, we're going to assign that medication as maybe they began a PGA. I won't be specific to the PGA that they were using. We've got capabilities to add it just to one eye if we were doing a trial, but in these cases also to identify the date at which we are adding those things in. So this can be really useful once we add it in, because it'll help us on that resetting the baseline and analyzing maybe where we've done something, clinically with the patient. But I'll get on a particular case here and stay on a date as we add the medication here. So here's your PGA again. Let's see if I can type. We're going to go ahead and we're going to choose a date of, going back. Maybe this was added back in 2018, and we'll say it was April 9th. It wasn't even a date that necessarily correlated or corresponded to a particular testing date, right? So we're not always going to run a set of diagnostics like OCT on the same date. We might have instituted this drop change a little bit sooner or later. And then we can also play with this, play with where we want to view. So if I wanted to just on this from a screen view say, well, I just really want to view everything back here, I can do it this way. Or I can reset what my baselines look like as well. And so in resetting the baseline, it would be around an OCT selection. So right now we're basing this off of our baseline in 2013. But in this particular individual, if I wanted to go and change that baseline to something that was much more recent, and maybe even that correlated or corresponded with the date at which I instituted the medication or had the medication change, we can do that. So let's say that we elected to change that baseline date to July 25th. in this particular case. And so it's going to change that here on the screen for us. We can see that during July 25th and July 6th that we don't have a corresponding RNF or a macular scan on that date. So it's going to change. We may want to adjust that baseline so that those all are in alignment. And you can see where that's, again, easily selectable within the way in which the program is set up here, where I can select these both, and now you've got two baselines that are set up. It'll give you little error messages as well down in here in terms of where your selections are at, if those don't match up with the data or the information that sits in the system. So just showing you a few different sort of capabilities within that. When we go back to that baseline, though, as a selection and making sure that you've got to also unselect your previous baselines. That does kind of screw you up a little bit. And your follow-ups and things like that also change. So when we reset all that baseline information, it will actually do what I just did by dragging this over and allow us to take a look from those dates on. Danica, how does this jive with the way in which you guys use it, and what kind of functionality you're currently employing in the progression analysis?
Yeah, I think that, you know, our technicians, they get the image, they save a GPA, and, you know, it's just going to be from the machine. It's going to be from the baseline, right? It's going to be from the original baseline. And sometimes that's not what I want. And so I spend most of my time when I'm looking at testing, I don't even have them print out printouts anymore. I just go right to form. I can manipulate what I want it to look like, so that it doesn't, you know, it doesn't give me, it's not helpful for me to look at a GPA that goes back, you know, 12 years if my patients had major interventions in the last 3 years, right? That's what I want to look at. And so sometimes I will even, you know, kind of toggle back and forth. I'll look at a GPA from, you know, using a baseline of 6 years ago, and then I'll look at I'll just change the baseline to my most recent intervention and see what are those rates looking like, because that's really how I can decide if my intervention has made a significant impact. And one of the things that I think I knew it, but I was a little nervous about it at first, is that nothing is permanent on here, right? So I don't have to worry that if I change my baseline and I made an error, oh, it wasn't supposed to be 2018, it was supposed to be 2016. I just go in there and change it again. And so it's really easy, it's really user-friendly to be able to make those changes. And it really helps me, I feel like it really helps me understand if my therapy is working.
Well, and to that end, as we were just having that, you were sharing with me what you're using. If you take a look, I did change that baseline. I kind of reset it to some of those dates back in 2016 and 17. And we can see, to your point that you had used on one of the static reports earlier, that the rate of change is significantly different. And all those little red dots that showed up before that were indicating, hey, there was a significant change, a clinically significant change over time, we can see and contrast that with the separate image from the ganglion cell, which is still showing that old set of data back to 2013. And you can see where interventions like a drop, and in his particular case, in this case, we had done a MIGS procedure in 2017 in the individual, and seeing also change there, as well as instituting these clinical events. And if we wanted to add, again, that surgery from a MIGS perspective, we can easily add that stuff in. As, again, picking a date, whatever date it might be that we wanted to do. And let's say that was in April of 2018. So we're adding that piece in. And here you have now everything, you know, sort of plugged and played together. And you've got these multiple clinical events that you can pay attention to as well, analyzing and then erasing or resetting those. Because let's say, to your point, that somebody did put something in error. The data is not so fixed that we're in trouble that we can't go and course correct that.
Yeah.
And Aaron, you mean one thing that you can see here as well is how the RNFL thickness profile has changed, so that you're not getting those reds or the yellows. So yeah, again, as you read baseline, yeah, there you go.
That was the first thing I noticed when you did that, when you went back to this, Aaron, is that those areas of red that we had on our instant plot, you know, they just went away. So you've definitely made a difference in this patient's progression rate.
Yeah, and so, you know, not to spend too much time in forum, while it's an extremely powerful tool, I think I would really want to highlight for our attendees that our management of these conditions is not static anymore. And it may not have ever been static, but it felt static at times when you rolled out the scroll of the visual fields that went down the hallway, right? Or when you tried to figure out, as you sorted through your OCT reports, which report do I want to pay attention to and where's that date? To have it all at our fingertips here, to be able to touch it, manipulate it, understand and input clinical events, and have an idea that, wow, this really worked. I didn't have to dive back into my EMR, and I didn't have to, check and see what kind of other medication they might have been in through a SureScripts or an AllScripts that I was on. This is a powerful set of tools that are kind of syncing these multiple modalities and allowing us with confidence to deliver this to patients. And I would say one last kind of closing remark. When I show this to a patient, they can see what's happening with their condition. And I can tell you that every single patient that sees this understands and is more committed to their course of care because they can actually visualize it and they don't just have to take my word for it.